Welcome to the England and Wales ITPSA Board Association patient Zoom meeting for August, nearly September. It's been a while since the last one, but lots of things have been happening. Just so you're all aware, this meeting is being recorded, and the reason for that is because we have lots of requests to actually, put the recording of the meeting on their YouTube channel, so others can see it, or people who attend the meeting can actually refer back. Just like to introduce a few of the people who are on tonight. Firstly, our expert is Professor Adrian Newland.
Hi.
Yeah, thank you. Then we've got senior patient mentor Rhonda Anderson.
Hello, everybody.
We've also got board members Derek Elston.
Evening, everybody.
Anthony Hurd and Diane White. There's Diane. And myself. Because we've got quite a few people on, if you do have a question, please raise your hand from the button at the bottom. I think it's in the reactions button at the bottom of your screen, if you have a question, and then it'll be a lot easier for us to actually see who's got a question and who hasn't. But I know Rhonda's got one about, because it's in the news at the moment, and there was a talk yesterday about bringing forward the booster vaccines for COVID. Rhonda, you got a question about COVID?
Yes, actually I have COVID at the moment, so I just wondered if, for the sake of everybody really, now that COVID's come up again, about the isolation period. We were talking about this before we all came in, and also about how long you have to wait after you've had COVID in order to have your vaccination. Thank you.
Yes. And there's an interesting issue, and I think that there's been a tendency to think over the last few months that COVID has rather gone away and it's not so much of a problem. But in fact, there's been a steady stream of it, albeit fairly mild infections, and the number of people needing to be admitted or ending up in ITU, and particularly the latter, has been very, very small. And that reflects the fact that a significant body of the population have either had their full immunizations or have had a previous infection. And either of those give good protection and certainly seem to reduce the severity of any infection. And if you had the immunizations and a dose of COVID, that's probably best of all. I mean, in terms of how long you should isolate, it depends very much on the symptoms and how you feel. And some people, it goes on for a few days. I know when I had it, within 24 hours, it completely cleared. I had quite a headache. I had very aching muscles, but within 24 hours, it had completely gone. Now, my testing remained positive for 10 days, which was quite aggravating because my wife was in hospital at the time and I wanted to go and visit her. And the hospital were quite clear that 5 days after my infections, my symptoms had cleared, I could go and visit. And they were quite happy for me to do that and didn't believe that I was infected then. So I think as a sort of rule of thumb, if you've been infected and you're over the symptoms, within 5 days you don't have to isolate, and I think that's quite reasonable. I mean, obviously, I would certainly say to people with the boosters coming up, obviously with the news today, they're suggesting that the boosters start a month earlier than they were planning, so in September. So I shall phone up my local boots and book for my flu jab and my COVID booster jab, being too young to have got it automatically earlier in the summer. But if you've been infected, probably within a month of the infection, you can go along and have your immunization, and you'll respond to it. So that would be my suggestion. There's no clear scientific evidence for that, but as a rule of thumb, you're over the acute part, and your body still will respond to the immunization. I mean, our bodies are coping with bugs all the time and are fighting them. So it has a very big capacity to deal with bugs that we approach. So that would be my advice for that.
Okay. Any questions on that one? Peter? You're muted. You're muted. Peter, you're muted.
Can you hear me now?
Yeah, we can, yes, sir.
Oh,
Yeah.
thank heavens for that.
Fire away.
Right, thank you. Sorry about that.
That's okay.
Right, I've read in today's paper about the boosters being brought forward to the 11th of September. But what it doesn't say is whether the boosters will be adapted to cope with the strain that's more worrying, which is Pirola. Does anybody know?
I think it's very unlikely that it'll be boost for that because it's relatively new. It's been coming up over the last 2 to 3 months, and I suspect that it won't cover that. From my reading of it, that the Pirola variant is a relatively mild variant, although it does seem to spread. So there may be quite a number of infections from there. But I think what they're doing by wanting to bring the booster forward is to increase everyone's general immunity. And what it's important to remember is that the immunizations, and particularly if you've had the full range of them, so most of them will probably have had 5, and this should be the 6th, and they've given a mix. I think I've had all of them when I look back over the little cards they give you over the time, and they're all aimed at different areas of the COVID. So the new virus, although it's slightly different, has many elements that it shares with all the other COVID viruses that we've seen since 2020. So it's quite likely that if your immunity has been topped up, that while it won't stop you getting the infection, it'll almost certainly curtail the severity of the infection and the length of the symptoms that you get. So although it's not specifically aimed at that, it will actually almost certainly reduce the severity of any infection that we get. And I think that's one of the reasons they want to do it, because what they're trying to do, most of the people who've had their last boosters 6 months plus ago, which means our active immunity is a bit lower. So they want to boost that to reduce the severity of any infections and reduce the impact that potentially has on the NHS.
Okay, does that answer your question, Peter?
Thank you. But maybe I could share something I've learned, which is that I attempted to get the special, I don't know what the right word is, booster, which is very hard to get once you've got COVID. And I asked the GP said no. Anyway, I found 111 absolutely fantastic. And I looked at the various things that you can have, and the one that appealed to me was, hope I've pronounced this correctly, Citrovimab. It's an intravenous drip you have of 500 grams for half an hour. And unlike the tablet options, whilst it may not be quite so effective in reducing the potential severity of COVID, it does shorten it as well and reduce the potential severity, but it doesn't have any real side effects, and it doesn't. It also merges well with virtually any other drug that you happen to be taking. I found, because it cost £2,000 a go, I found it really difficult to get it. But the key to the door, unfortunately, was not ITP. It was my aortic regurgitation, which put me at risk of getting an infection because of the COVID. And within a few days, I was into the vaccine hub, and very simply, I had this infusion. They looked after me with taking my blood pressure and my temperature for an hour, and then let me go. And I've had no side effects, and I feel pretty lucky to have obtained it. But I pass that on for what it's worth. And yes. I think the two keys to the door are 111 at any time. And obviously they have a checklist, but eventually you get referred to a 111 GP, I found. And that's when eventually one of them said, yes, we will refer you. And within a few days I had it. So I'm afraid the key to the door isn't necessarily ITP, but magic words like cardiovascular problems or frailty, or if you Google Citrivibab, you can see the list of conditions you need to have in order to qualify. Things like leukemia, etc.
Yes.
will get you through the door. I pass that on for what it's worth.
Thank you,
But
Peter.
that's an extremely important bit of advice and reminders, because as many of you will be aware, there are some antiviral drugs that are now used for people with COVID, and they particularly restrict them for those who are sensitive or at risk, and they don't consider ITP to be an at-risk disease. But there are various other things where your immunity may be a bit suppressed if you had chemotherapy or a malignancy, or particularly hematological malignancy, or you're on certain drugs where they will treat you. And actually, they're really good at that, of winding up the team and getting you that antiviral therapy. The treatment you're talking about is a sort of variant of what most patients with ITP are aware of, which is intravenous immunoglobulin, in that it's a more concentrated element of antibody that helps neutralize the infection when you've got it, and helps your body clear it. So yeah, that's really good advice, Peter, and that's thanks for reminding us of that. And that's very useful.
Good.
Thank you, Adrian. I've actually got a question here from a lady called Mary on behalf of her husband. Her husband suffered from ITP for around about 8 years. He was first on steroids, and then about 2 years ago was put on eltrombopag without too many problems. And his platelets were going up and down, but he was fine. He also has a stoma. But however, in the last month, his blood results showed that the kidney function was dropping dramatically and continues to drop. He's now been referred to the renal department at Royal Sussex. Could this be down to eltrombopag? Because one of the possible side effects is renal function.
I'm not aware of significant renal problems with eltrombopag. And particularly if he's been on it for a long time and they're maybe periodically monitoring that, I would think it's unlikely for that. But clearly what he needs to be is assessed by a proper renal unit, so they can measure, so they can look at all the other potential causes of decline. If necessary, they can stop eltrombopag and swap it for something else, like avatrombopag, which has different events and is oral and works in very much the same way. But my general feeling would be that it's unlikely to be specifically related to eltrombopag. You can't 100% rule it out. You can't 100% rule out anything, but it's not the first thing that would spring to mind for someone who shows renal deterioration, who's been on eltrombopag for a long period with stable renal function. But obviously he needs to be assessed by a proper renal unit.
Okay, thank you, Adrian. Thanks for that one. Any other questions?
Yeah, I was just going to raise something that we talked about on the recent support group with Scotland, and it's a topic that comes up regularly on all the various social media platforms, and I know something that people are interested in. It's the topic of looking at alternative treatment for ITP. So you get all sorts of ridiculous things advertised on the internet these days, and on the various social media sites. One I know particularly that I see a lot of is papaya leaf extract, and I'm just very wary that people get drawn into doing something that certainly isn't going to help them and probably will cost them a lot of money and maybe make things worse. So I just wondered if there was any sort of general thoughts and comment on that for people to take away.
Yes, it's a very interesting area, and I've never stopped patients taking complementary medicine if that's what they want to do, but I've always suggested to them that if they want to try something, to let us know what they're taking, because I've certainly had people who had complementary medicines that have actually been detrimental.
Yeah.
Iodine extracts, for instance, which can poison the bone marrow if you're taking in high amounts, and there are various other things as well which are not good. I mean, I've always told the story of a patient who came to see me with ITP that had responded poorly. He came to see me as a second opinion, and he carried with him a small rucksack. And in that rucksack, he had 29 different types of complementary medicines that he'd bought he'd bought over the internet, because what he'd been doing is researching things. He'd come across things that boost his immunity, that improve his platelet function, that stimulate his bone marrow, that improve his blood vessel function. And there's no evidence that any of these things do what you claim they will do.
No.
I mean, I have to say, I looked at them and thought, well, I didn't see anything there that I immediately thought was detrimental. But equally, I couldn't say to him I saw anything there that I knew would help.
Yeah.
Even things like he didn't have anything like tranexamic acid, which some of you may have come across, which helps stabilize your clot and reduce bleeding. But I think the important thing, I think from a medical point of view, or from a doctor's point of view, is to encourage your patient, not belittle your patient's choices, encourage them to share with you what they want to take. So, and if you know it's harmless and makes them feel psychologically better, I don't have a problem with that.
Yeah.
But what I don't want them to do is spend a fortune on all these things because they're convinced what they read on the internet. I mean, I have to say, I found in the UK people are generally much more sensible than that. But if you go onto the American sites and you look at some of the discussions in the PDSA, and I'm appalled at the at the advice they give each other, where they're convinced that this is the one thing and everybody should take, and you go, well, there's no evidence of that. But anyway, I think Rhonda wanted to make a comment.
Rhonda, you got your hand up?
Yes, I just want to absolutely endorse what Adrian says as a layperson, because obviously Adrian is the medical side of things. I think that, I've written about some of this in the platelet and so on, and I've researched it quite a lot because I'm quite interested in, natural therapies that people, as they say, strychnine's natural and so is hemlock, and you can die from them. So keep well away.
You could get into big trouble if you happen to rub a foxglove up the wrong way as well, couldn't you?
Yeah, definitely.
Is, not good.
Yes.
So I think that, as Adrian was saying, I just would like to say that, if people want to go and have something like a massage or reflexology or something like that, that makes them feel better and actually takes away some of the anxiety that they have about their condition. Because I think this is really what drives this whole thing, is that people are very anxious about their condition and what's going to happen to them and what can they do. Because I think some people too who have a long-term condition have a sort of, they would never admit to it, but they have a sort of inbuilt guilt that they feel, it must have been something that I did that gave me this. And so now I've got to find something that's going to make it better. And I think that a lot of people find different ways. And, every article I write practically says, live a healthy lifestyle. Go and do all the things that everybody tells you to do, like go out and walk and get exercise and eat a sensible diet, lose weight, and all those kinds of things. It's much better to concentrate on your healthy lifestyle than it is on spending loads and loads of money. Spend the money on good food instead of spending it on pills and potions. That at the end of the day, someone behind all of that is making an awful lot of money out of you. So, the bottom line is, has it been scientifically investigated? And have the scientists said, yes, this is a good thing to take? And you will find that there is very little scientific evidence for any of these things.
Also, the other thing is they're not regulated in any way.
That's right.
How much of them do you take? What is the suggested dosage? What dosage might work for one person and not work for another? There's no actual record, as you say, of what works and what doesn't. So, as you say, it's a bit of a minefield, but it crops up time and time again on the social media forums.
Yeah, it does.
Yeah.
Because people are desperate.
Of
I mean,
course,
this is why people go and spend so much money on all of these weird and wonderful things that they can do. But always take a step back and think, you know, am I just giving my money to somebody who's trying to get money out of me? Or is this a really scientifically proven thing that doctors and scientists have said? So, you know, the healthy lifestyle is the one to concentrate on, I think.
If it sounds too good to be true, then it probably is too good.
Absolutely.
To be true.
Okay, Jane, you've got
Thanks.
your hand up. Yeah.
Yeah, I just wanted to add something to that. I mean, I'm relatively newcomer to ITP, maybe had it for about 5 years. Oddly enough, I never and still don't have any symptoms. Nothing presents itself, but I'm sure that happens with a lot of people. I just happened to find out by chance that I had it, like lots of other people, I'm sure. So over those years, I've had, I've been thinking, you know, asking the unanswerable question, what can I do to prevent relapses, remissions into an unstable position in terms of nutrition? And I'm very interested in ultra-processed foods, the unknown impact that's starting to emerge now in the press about the danger of our diet and ultra-processed foods. And I just think that it's really important that more money is put into research on the impact of the nutrition that we have on our body, on our cells, how they function. I'm not a medical person, so there's probably lots of research, but I personally would like to know a lot more about the impact of nutrition, not just as an ITP patient, but just generally as somebody who's beginning to realize that ultra-processed foods and the chemicals that are in them are so damaging, whether you've got ITP or not.
I know that.
Sorry,
that's a really interesting point, and I think we don't know what the impact of some of the chemicals within ultra-processed food do have. Some of the food additives, some of the preservatives, some of the things that are used to stimulate plants. And it surprised me actually with the publicity recently, looking through some of the things that were called ultra-processed, like yogurts, which I'd assumed were actually relatively natural. I mean, I have to say, I think for the majority of patients with ITP who talk about diet, my main advice is if you eat a normal, I wouldn't say organic, but what I mean, perhaps fresh diet. I mean, not takeaways and processed foods and pizzas and things like that. If you eat a normal diet, you get all the nutrients you need that support your bone marrow and support your health, which I think is crucial. But we really don't know what within a lot of the foods, what happens to them. I mean, you get a whole list of things. You have no idea what they mean. One of the old advisors to the association and the American advisors, Professor Jim George, who used to come over and speak at the association until probably about 5 years ago when he retired. He was for the first 20 years, he was an enormous supporter of the association, who was probably one of the men in ITP in the US and did a lot of work there. And he got one of his research fellows to go through all the literature to find out if there are any of the sort of these additives or chemicals that or so-called complementary medicines that had any impact on ITP. One of the things he came across, he found nothing that of the complementary medicines that had any positive impact whatsoever. You can always find the odd report where someone takes something and it all improves, but an anecdotal report is purely that. It's just an association rather than a causative event. But I think the work hasn't been done on the contents of food. There's quite a lot of of evidence that what happens in the gut, the so-called gut microbiome, which essentially means the makeup of the bugs in the gut, have an impact on our immunity. And the association did fund some work on this some years ago through Cambridge, and we did a lot of funding for this. And unfortunately, the results that came out were absolutely unhelpful whatsoever. Although I think some of that early work was I'd say fairly primitive, in that it wasn't as refined as the techniques we have now. Well, one of our advisors, Nikki Cooper at Hammersmith, is trying to do a little pilot project at the moment, looking at some of the more refined techniques. And we, as an association, we've given her a little bit of funding, not much at all, just to buy a few reagents and things to help her to see if there's something going on that will allow her to go for a bigger grant and actually do a proper study. But I have no doubt that what happens in the gut has important implications for our immunity and what's happening to us.
Undoubtedly. Undoubtedly. I know that I've just put a little note on the chat there that I know that we, the association, funded Professor Hunter to do some research at Addenbrooke some years ago. And I don't
that was the one I was talking about.
Yeah, I don't know that there were any real actual conclusions firm.
It was totally inconclusive.
Yeah, it wasn't anything firm one way or the other, was there? So I think it is on the website, Mervyn, isn't it? Still, if people
it is, yeah, it is there. Yeah.
I thought it's worth mentioning that.
Okay, there's a few people with their hands up.
Just about in there. I did try and he retired.
Oh, right.
Fully. I mean, we were essentially funding post-retirement research, and they retired entirely. And I tried to get in touch with them a couple of years ago to say, would you like to produce a definitive report that we can put on our website just to let us know what you've done? And I got no response, which was disappointing.
Right. Yeah.
Okay, we got a number of people with their hands raised. Rhonda, you was first.
Right. No, I just wanted to say, and I mean, Adrian can correct me on this if I'm wrong, the ITP is an autoimmune disease. So therefore, it's very difficult to pin down. I mean, there are several autoimmune diseases, you probably know, lots of different ones like diabetes and so on. And there is no, so far science has not really come up with the reason for them, except that we know that it's an autoimmune disease. So that's one thing. The other thing is that there's quite a lot of stuff now, books that have been published about the ultra-processed diet and all kinds of other diets. Michael Mosley is one who does that kind of thing. And also, I can't remember, is it Zan Van Tulleken?
Yeah.
He's the other doctor who does things. So it's worth looking up, maybe on the internet, see if you can find something on the internet first. And if not, look into their books. They are around. And also there are programs on Radio 4 and places like that where you can pick up things. But I mean, again, it's very important to go to people who know what they're talking about, because those two people are doctors. And so they do proper research.
Yeah.
Okay, thank you, Rhonda. Right, Ray Holding. Ray, nice to see you.
Hi, good evening all. Just going back to Adrian's chat about guts. Interestingly, I was talking to a young early days researcher just a couple of weeks ago who is going to be looking at illness in the guts and the microbiome. And I happen to just have a piece of information which said that Hippocrates, 2,500 years ago, something like that, said all illness starts in the guts. So maybe that's a way for it to go forward. The other one was I've been looking at some social media where people have been tested for H. pylori with ITP, and then they've been treated for the H. pylori, and lo and behold, ITP has disappeared. Any comments on that?
Yes, I mean, H. pylori is an interesting thing. I mean, we've been looking at that for probably 20 years now. It varies throughout the world, and the different types, what they call serotypes, they're just ways of discussing different types of the bug. In Japan, if you have ITP, they almost automatically treat H. pylori before they do anything else, and a significant portion of those recover. The Americans who also tried that have had no response whatsoever. We did a European study, which we published, must be 10, 12 years ago now, where about half of the patients recover if we treat H. pylori. But in general, unfortunately, those who recover are the ones who probably didn't need treatment in the first place, i.e. their platelets were low, but not crashingly low, i.e. not less than 10. And it unfortunately means that although we know H. pylori is involved with sort of immune response, there's probably some cross-reactivity with the antibodies that affect platelets. Treating it, certainly in Europe, has some impact. And although the advice in the guidelines was that you should look for H. pylori as part of your initial studies, most people now will only look for patients who are refractory to initial treatments. And it probably in part reflects the different types, different strains of H. pylori throughout the world. Just coming back to the issue of autoimmunity, I mean, deficiencies in autoimmunity are the key problems in ITP. It's the balance between preventing us developing antibodies against platelets. And we all produce antibodies against our bodies all the time, but our immune mechanisms stop those becoming important. And in various conditions, of which ITP is one, but diabetes is probably the main example, you develop, something goes awry and you develop antibodies against your cells. And you can develop antibodies against any area in the body. And as Anthony put up in the questions, there are sort of 80 odd autoimmune diseases. And it's well known that autoimmune problems are very common in the first 4 years of life before the immune system is stabilized. They're much more common over 60 when our immune system begins to go awry. I mean, it just wears out. So you're not as good at controlling your immune system. In the intermediate years, almost certainly if you develop ITP, there may be something that's provoked that. We don't always know what that is. It could be an infection, and we know infections can provoke ITP, but if an infection provokes it, it's almost certainly self-limited. It may be a reaction to an immunization, and we know this with pneumovax, we know particularly with COVID, although it's not as dramatic as the publicity would suggest. There's certain drugs that will impact on your immunity, and there's probably reasonable evidence that chronic stress will impact on your immune balance as well. So that's in part what's going on. And we know from the studies that we've done in patients who respond to thrombopoietin, and probably one or two other treatments as well, patients who respond to thrombopoietin, around a third will achieve a long-term treatment-free remission, i.e. the platelet count goes up, you can eventually tail the treatment off after 6-9 months, and the platelet count will stay up. And when you look at their immune system, you'll find that the regulatory cells that regulate immune function and antibody production have increased in the bone marrow. And at presentation, they're often reduced. In response, they come up. So something is knocking those regulatory cells at the start of your disease. And as I said, that could be an infection, it could be drug, it could be stress, it could be whatever. It could be the preservatives in your ultra-processed food. And it's quite possibly, it could be a mixture of those. So you've actually got to try and get the patients over that period. So whatever's causing the problem washes out of the system and things then go back to normal. I mean, that's a rather simplistic explanation of what's going on. And we don't have a lot of things to measure that are easy, but that it's all down to disruption in the body's immune balance for whatever reason.
Funnily enough, I read quite widely on a sort of more holistic approach where the argument is that it could well be something that has happened to you even in your early part of your life that has kind of been an event that is kind of stored up in your system and then erupts later in life when provoked by something else. So it's very difficult to prove any of that, but I can understand that may be a possibility, because we are very complex computers, aren't we, us human beings? You know? So,
I blame my mother for everything.
yeah, I blame everything on Tottenham Hotspur mainly.
Yeah. Okay, Jill,
That's
you've got
totally
your hand
unfair on my
up.
mother, I have to say.
Jill?
Yeah. Hello, everybody. I think you've covered some of my questions, actually. I was diagnosed with H. pylori last year, and I had 2 lines of therapy, and it didn't clear it. And I had digestive problems, so I had an endoscopy, and they looked into it and couldn't find anything. But at the same time, this year they came back and said, you've still got H. pylori. And I'm just wondering whether I've spoken to my doctor, and he says, well, if it's not giving you any symptoms at the moment, let's not treat it. So I don't really know whether to push for a test to find out exactly what type of pylori it is and be treated for it, or just wait until I get symptomatic again.
What's your platelet count?
Sorry, my platelet count is 220. So it's been very good. I haven't been on any medication for 2 years.
Oh, great.
I had a year of romiflostin, which I started at 80 micrograms, and it dropped down, and I had it it petered out over the year to once a month. And then my platelet count climbed to 220, and it stayed there ever since.
I mean, to be honest, with a platelet count running like that off treatment, if you've got no symptoms from your gut, just leave it. You don't want to take any tablets that you don't need to take, to be honest. There are 2 tests that you can do to look for H. pylori. One is a stool test, the other is a breath test, and it depends what's available locally. And all those will tell you whether you've got bugs there or not. It won't tell you you've got an infection, it won't tell you how much there is. So if you've got symptoms, I mean, if you've got gut problems or heartburn or indigestion or whatever, then it's worth having the treatment. And you take a mixture of 2 or 3 drugs that deal with that. One drops the acid down. There's an antibiotic that deals with it. But certainly H. pylori infection has been shown to be one of the key causes of gastric or duodenal ulcers. So if you get symptoms, it should be treated. But if you've got no symptoms and your platelet count's normal from an ITP point of view, there's no value in taking treatment, and all treatments have some side effects. It's not worth exposing yourself to it, to be honest.
Exactly. As I said, I had two courses of treatment. I had treatment twice with the 2 courses over a period of time, and because I'm allergic to penicillin, they were concerned. They didn't really want to give me a 3rd line and just see how I got on. So I'm okay with that. And as I said, I had the endoscopy because I was concerned that if I had an ulcer or anything, that might cause problems. But the endoscopy was clear, so I'm okay. I should say.
I would stick like that, to be honest.
Okay. And there was just another question then. So if I've been off medication for 2 years, am I in remission from ITP?
You're in remission, but not necessarily cured.
Right.
In that it could come back. It may not, and many patients don't. But there's always some risk that it will. And there's no point in having your platelet count checked. But if you have a problem, or if you develop bruising, then that's the time to go and have the count checked. There's no value in psyching yourself, say, well, I've got to have a blood test every 3 months to see what's happening, because you could relapse 2 weeks after having your blood test or whatever. It's not likely to happen, having been 2 years out. But if you've got an event like an acute infection, it may just provoke it. But the longer you're out from having had treatment, the more likely it is for the response to persist. But no one could say to you it will never come back.
No, okay. But my consultant just sees me every 6 months now because of the H. pylori connection.
Yeah, that's quite reasonable. Yeah.
Okay, thank you very much, Jill.
Thank you.
Thank you.
We've got a question, Adrian, on the chat from Simon. Is there any advice on how to identify what the underlying cause of ITP is? I've now tried most of the medical treatments, romiflostrum, avatrombopag, eltrombopag, etc., etc. But his platelets are stubbornly bouncing around between 4 and 20. The hospital is looking at options on next steps. That does not involve a splenectomy. Can you give any advice?
I mean, there isn't any good advice I could give about looking for the underlying cause, because I'm assuming that the hospital, as part of their pre-assessment, will have gone through all the causes that we know, whether there's an associated disease, whether there's any significant drug history, whether there's any underlying infection, whether there's any other problems with the blood, whether there's any associated condition that we know may bring the platelets down. All those are explained and discussed in the ITP, international ITP guidelines, which have been reviewed on several occasions and came out last 3 or 4 years ago. So I'm assuming that they will have looked at all those and will be able to say, well, actually, there is no obvious cause of this here. We just have to treat the disease as it is. And unfortunately, that's the case with the vast majority of people with ITP that we see. We find no underlying reason. It's then a question of finding a treatment that works. And unfortunately, Simon has had, just looking down his little list here, has had most of the main ones. And the issue is, it's a balance between platelets being produced on the one hand and platelets being destroyed on the other. And if they're not producing enough, then any normal destruction will drop the count. If you're producing a lot, but destruction is souped up, then your count will still fall. It's a question of either, and most of the treatments are either designed to increase the platelets, and he's had Romi, eltrombopag, and avatrombopag, all of which increase platelets. He's had the treatments that actually reduce destruction, which are that he's had rituximab, azathioprine, and mycophenolate. I'm assuming those have been pushed to maximum doses and treated to the sort of periods that we normally expect to treat before we can say this has not worked. What we do then is try to look at a balance of treatments to see if we can give treatments that provoke platelet production while at the same time trying to damp down the destruction of the platelets. And we occasionally find, particularly with the thrombopoietins, any of the first 3, if they don't have a good response, you may add in a small dose of steroid or something else, which just sufficiently reduces platelet destruction for the count to come up. And we don't need to get it up very high. I mean, obviously, if his count remained at 20, he almost certainly wouldn't bleed and you wouldn't worry about it. Obviously, when it drops to 4, you do worry. And we would all aim to try and treat someone whose count is usually less than 10. So I'm sure the hospital are now currently looking at that sort of balance. To be honest, talking about the issue of splenectomy, and he clearly doesn't want to involve splenectomy. It rarely works in people who've got chronic refractory disease. It tends to work. I mean, it's very interesting, and I think we presented our work at our review of this at the ITP convention a year or so ago, where we looked at the impact of splenectomy. And the trouble with splenectomy is it has a very good publicity. And people say, well, it works. And what we found was that, yes, it worked very well 20 to 30 years ago. It works less well now. But when you actually look at the people who were treated 20, 30 years ago, most of them didn't need a splenectomy because they were treated too early. You know, the old mantra that you give steroids, if that doesn't work, you take the spleen out. Many physicians used to do that, and there possibly some still do. They didn't treat long enough to see the patients would actually properly respond. What we found when we started looking at what we call spleen function, at platelet survival, that those patients with that sort of poor refractory disease have platelets destroyed, not just in the spleen, but elsewhere, and taking the spleen out is irrelevant. And that often incorporates those patients who have responded poorly to anything. patients who respond well to splenectomy are normally those who have a good response to steroids that's not sustained, or a good response to IVIG that's not sustained. They'll have a good response to splenectomy, but they'll almost certainly be those who respond well to things like the thrombopoietins, the ROMEs, the L-trombophags, the others. And so, and then almost certainly wouldn't need that splenectomy anyway. And we've found our splenectomy rate has dropped absolutely dramatically, as it has in the rest of the UK, as it has in Europe. Even some of the countries where they were very keen on splenectomy are doing much, much less because they realize how unnecessary it is. And it has long-term impacts. You've got to be immunized, you've got to take penicillin for a period, and you're still prone to infection, and you still have lost a third of your immune function, your immune capacity.
Okay, thank you, Adrian.
I was just going to add one other thing, because Anthony mentioned it and I thought of it then, talking about the gut. Actually, an enormous amount of your immunity is based in the gut. The gut has nodules of lymph tissue, and that's part of your defenses. So when you swallow bugs and things like that, these lymphocyte pockets within the lining of the gut pick up the bugs and develop immunity to them. And the gut is an enormously important
Also
function.
If your brain is unhappy, your gut will be unhappy, and vice versa.
Yes.
Simple as that.
Yeah.
They talk to each other all the time and basically control what's going on.
Yeah.
Okay. Does that help, Simon?
Yeah, no, it's good. Yeah, thanks. Yeah, I mean, I've had ITP for 3 years, and I seem to have fast-tracked every treatment going. So I spoke to the CNS nurse earlier, and she was looking for a sort of a national lead on platelet destruction.
Yeah. Well, what part of the country you're in?
Bedford. So
just up the road here.
Yeah. Yeah, I actually live in Bromham, so yeah, not too far.
Oh, okay. I've got friends there. Yeah.
I made a little note on the chat there, folks, for a very good recommendation of a video on our YouTube channel by Professor Semple, who gave a talk to us at our convention about why ITP occurs in terms of what's actually going on in our bodies when it's happening, and how it develops. So I thoroughly recommend that. It's done in a very easy to follow way and a fun way as well. So I thoroughly recommend that.
Okay, right. Before I go to Rhonda, who's got her hand up, we've got 12 minutes left, because we do have to finish at 8 o'clock tonight. So if you've got any questions, get them ready now. Rhonda?
Right, well, just to add, to muddy the waters, I have had a splenectomy. I had it in 2000, and after some while, it actually did fix me. But, I'm not saying that it should, that's just my story, okay? The other thing that I would say, and this is what I say to people who ring me up or email me, and they're having a terrible time with lots of drugs and things, I always say to them, go back to your clinician and have a really sort of heart-to-heart discussion about whether you could actually have a trial period of coming off everything and just see how you're going. Because if you've got platelets of 4 and the drugs aren't actually seeming to do what you want them to do, and why not have a try of not having any drugs at all and just see what happens?
Watch and wait.
I mean, that is very personal to you, whether you want to do that, whether you feel confident to do that, whether your clinician would agree. But I think in the situation that you're in, you really need to sort of, it depends how much ITP impacts your life and how frightened you are of it doing something really bad to you. But in your situation, that's what I would do. And I can only speak for myself. I don't know what Adrian thinks about that.
I think that's a very common attitude amongst many ITP docs. If you've actually ploughed in with lots and lots of treatments not working, is to aim for a treatment-free period, just in case some of these treatments, particularly the immune suppressive ones, are suppressing your bone marrow function. Now, in terms of splenectomy, I don't want to say that splenectomy is irrelevant. Splenectomy certainly works, and in some patients it's actually very effective. What I want to get away from is the mindset of the physician who says, we'll trial these, and if they don't work, we can always take your spleen out as a last resort, because that's the one that rarely works. And it's raising your hopes that you're going to have to go through all this, and you're going to have to go through what's significant surgery. And you can almost predict beforehand that it won't work unless you maybe look at platelet survival or platelet destruction tests and say, well, actually, this may work. And from Simon's point of view, I think Addenbrooke's used to do it. I don't know if they still do. I've rather lost touch with the person who used to be involved with that there. But I would certainly, just without knowing any details of your dose of drugs and how long you've taken them, of saying that if you're running counts that level, I would avoid a splenectomy unless you can be positively convinced it's worth doing.
I'm not recommending it, put it that way.
No, I didn't think you were, Rhonda.
I know. We know each other really well. Adrian knows my case and he knows what I think. But, you know, it's just to sort of add to the discussion.
Yeah.
Okay. Thank you, Rhonda. Just before we go to the next question, if there's one.
Is Alison waving a hand to ask a question?
I never saw that. Was you Alison?
She didn't put her hand up. She just was waving a hand.
Yes, hi. I didn't know how to do the hand thing. I've been diagnosed with ITP for 9 months now, and my blood platelets are fine. The initial diagnosis is through blood, I guess. I had a skin rash, the skin rash. Now my haematologist wants me to have a bone marrow test. Well, I Googled it and what's the procedure, and I'm terrified I don't want to have it. Why do I have to have it if my white and red blood cells are fine? And it's just my platelets levels are about, at the moment, I'm not on any treatment, they're about 50 to 60.
Well, you need to ask him that. I mean, most people don't do bone marrow tests now unless the treatment hasn't worked. But you've clearly had some response. If there's a reason why now he thinks, well, there's something here that I'd like. I mean, there are 1 or 2 tests you can do on the bone marrow that you can't do on the blood that he may want to do for a specific reason. But in general, we wouldn't do a bone marrow. We don't do a bone marrow as part of our diagnostics now, unless there's something else we suspect is going on. And if a patient had a partial response and the rest of the blood's normal, again, we probably wouldn't do it. But without actually seeing your details, I couldn't say it's the wrong thing to do. All I would say is you need to say to him, why do you want to do this now? Because from my point of view, things seem quite steady, and I'd rather just leave it and wait and see what happens.
Well, he says to me very quickly that he just wants to make sure to rule out anything else that's there.
Yeah, certainly I had a bone marrow test myself back in 2010, just before they gave me rituximab. And I can't use language before 9 o'clock that would describe quite how bad it was, but never mind. The eyes watered for a couple of weeks after, but there we are.
I mean,
it's not that bad. It's not that bad. He's a man. Don't listen to
maybe I've got very low pain. I've got a low pain threshold. And
I've had two done.
Calm down.
I've had 2 done, and I've driven.
Karen, you got your hand up.
Yeah, I'd like to reassure people, if you have good local anesthetic, and if you have some places will actually give people a mild sedative. I've had 2, and I have driven after both of them with absolutely no problem.
Most people would use what Karen's done. Will give a mild sedative.
Yeah,
the sort of thing you give before a gastroscopy or whatever. And will you also use a local anesthetic? There are some where you do all these things and it still seems to cause a lot of problems. The vast majority is pretty pain-free and easy. I think Ray, with his magnificent dog, may want to have a comment on that.
I'm glad you like the dog.
Yeah.
In bone marrow, I had one within 7 days of them being admitted to hospital, and I'd heard all the terrible stories, and I was prepared to bend the hospital bed rails, but it was done and over with. Did it first, and the senior registrar said to me, "We'd like to get another one. Can we do it now? I said, well, yeah, please do, because why do I want to get back in here again? But they did, no problem at all. So I guess there are people who have got very low thresholds of pain. Not pointing at Anthony, of course.
Supporters.
Yes.
I think it's who's doing it as well.
Yes.
Makes a huge difference.
If you get a sort of what are they called, a 7, the junior grade doctors, you get a 1, and you know he's done it a few times before, and you don't.
I think I must have had the cleaner that day.
If you have a specialist unit, it's often done by the nurses who do them all the time, and nurses are far better at these things. Anyway, I mean, coming back to Alison's point, there are 1 or 2 tests that we can only do on a bone marrow to exclude other things, but there may be suggestions from other tests as to why we want to do those. So it's not necessarily, it's no good at all just to diagnose ITP. It's really poor at diagnosing ITP, but it can be used for 1 or 2 sort of esoteric conditions that can be associated with a low platelet count. But you'd want to get your doctor to persuade you why he wants to do it at this stage.
Okay, thanks. Right, we've got a couple of minutes left. Just very quickly, Anthony mentioned some of the videos on our YouTube channel. At the start of Awareness Week next month, September the 25th, we've got, I think it's just over 10 new videos dropping onto our YouTube channel from our convention last May. So a number of the talks were recorded. So people may well find those useful. In addition, we've got another one of these meetings for paediatric patients and their families during Awareness Week. And we're also working on a webinar with our colleagues in the USA, Australia and Italy, which will take place during Awareness Week. So just keep watching our social media channels for any updates. But we've got 2 minutes left. Any questions? If anyone, Ray again, but just want to say, if anyone thinks of a question afterwards, if you email me, I'll get it to the right people who can give you an answer. Ray, you got another quick question?
No, not a question, Mervyn. It's a sort of an aside. We see lots about fatigue with ITP, and it's certainly something which I'm very familiar with. I'm talking about the videos coming up. There is a Cresta Clinics in Newcastle who run a very good fatigue overcoming session, mainly designed for long COVID patients, but it's equally applicable to ITP patients who are suffering from fatigue.
Okay, could you send me the details of that, Ray?
Sorry?
Could you send me the details of that, please, and I'll have a look.
Yeah. It's an hour. And there's 4 people who are involved in it, and they all give their own little chat. Very interesting little one, and certainly they come up with ideas which you can apply in standard life.
Yeah. Okay.
Sounds good. Yeah.
Great stuff. Well, if there's no more questions, thank you, everyone. It's been a really useful hour. I hope you've all found it interesting and informative. As I said, if you think of any questions afterwards, just send them to me by email, and we'll try and get them answered. And look forward to seeing you all again at the next one of these meetings. Thank you very much, everyone.
Thanks,
Okay.
Mervyn.
Thanks, everybody.
Thanks, everybody.
Bye.